Alrighty, so let's get started. Hopefully we get a few more participants to join during the session. All right, so thank you all for joining us today. Welcome to session 2 of our Learning Collaborative on incorporating peer support into substance use disorder treatment. This is just some information in case you didn't attend the first session. The National Center for Health and Public Housing. Our mission is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and technical assistance. Also, the contents of today are those of the author only, and they're also 100% financed by the HRSA grant listed on the screen. And then with us today, we have Dr. Kevin Lombardi, who is our Director of Research. He will be presenting some information today on research-related literature on peer support for patients with substance use disorders. Also, here I am myself, Fide Pineda, I'm the TTA manager, and Jumoke Oladipo, who will be co-moderating today's session. And this is just a reminder to all participants that you're muted. Please also make sure that you engage in the chat or that you also engage verbally. We strongly encourage for you to try to engage verbally as well. And please make sure that you raise your hand if you would like to chime in or if you have any questions. This meeting is also being recorded. The slides and the recording link will be sent to you all after today's session. Okay, and now without further ado, I will pass it on to Dr. Kevin Lombardi to kickstart the Learning Collaborative.
Okay, let's do it. Today, we are going to take a deep dive into a meta-analysis. I was just talking to Jamoke about this. Maybe it was just Jamoke, like maybe an hour ago, where I talked about the difficulties of interpreting scientific papers. Was this you?
Yep.
It's hard. They're in a different language. I remember my first class where I had to do a lot of them, use a lot of them when I was in undergraduate, and it was like reading Greek to me. Today, we are going to take a good meta-analysis. We are going to chop it up into digestive pieces. As we do that, I'm going to show you the tools, the practices, how to do this with these papers. And we're going to talk about what the paper says and translate it to practice live on TV. So there's going to be questions. There's going to be case studies, short ones in between. Just roll with me. And remember, this is fun and participatory, and we are going to get into the bottom of this as deeply as we can. Next slide, please. The system, you know the system. Go through this in the next slide and right into the case, Fide. And the next one too, please. Okay, so let's define the terms before we get into it, because peer support looks different everywhere. Back one, please. Yeah, right there. Peer support looks different at every institution because everyone has different people who can do different things, and they have different protocols for using it. Peer support therapy has some standard definitions that are used in the literature, and the literature tends to look at those specific interventions, types of peer support. For example, types of peer support and outreach. For example, partnerships and coaching. Individuals where are they going to recruit folks? Where are they meeting them the first time? How are the services being introduced? What the data tells us is these things have a lot of impact on how likely someone is to use the services and how likely the services are to help them. So we're going to look at that. But here's the overarching theme here. Peer recovery and support services are peer-driven, mentoring, education, and some support administrations. And those three different pieces are very key components here. They are delivered by individuals who, because of their own experience with SUD or SUD recovery, are experienced and qualified to support peers currently experiencing SUDs and associated problems. They are guides. Next slide, please. Okay, so here's the paper. We're going to take this, look at it, and see what we can get from it. Next slide, please. Looking in. Okay, so when we start with the first page here, we get the introduction. When I look at a paper, I start with the abstract. It depends on what I'm doing, but say I'm looking at something to affect my practice. I'm looking at something to either validate something I'm choosing to do or to give me the what to do in a certain clinical situation. Very common thing that a very common clinical problem for a physician, and I would say a very common clinical problem for everyone. So having the understanding of how to pick these things out can save you a lot of time. Start with the abstract. I look at see to see if there are things there that are the results are important to what I'm going to do, and then I read in. The introduction will give you the literature review, and with the literature review, you can get some really critical background that helps found your knowledge. Next level, please. Let's see what it says here and see what we can take for it. An interpretation exercise. Okay, so this is describing the study. When you pick up a scientific study, you need to evaluate whether it's worth your time to read it or not. These things take time to look at, and they take a lot of concentration. So the first thing to do is to look at the characterization of the study. So uh, this is a lot of mumbo jumbo here, but let's try to take it apart. Jamoke, we'll start with you. I'm going to read this, and you tell me what it means. So we have here a systemic review characterizing existing research. It lists the research types on peer support recovery services. Findings speak to the potential of peer supports across a number of SUD treatment settings, as evidenced by positive findings on measures including reduced substance use and SUD relapse rates. What does that mean?
Um, they got together to look at research and they found that peer support helped in SUD treatment. And the measures they used to find that was relapse rates, improved relationships with treatment providers and social supports, and treatment retention.
Yeah, nailed it. So that's the thing when we're looking at treatment and treatment options that we like, things like peer support. They're not just there because they're fun, they're there because they are effective. And this is the underlying of what we do. And okay, we got this background here. Next slide. Okay, the introduction gets into a lot of context that's really key to understand with SUD treatment broadly and when considering peer support. So we look here, and the article starts by introducing us to peer support. Substance use is a major public health challenge. We all agree with that. But we can see that many who meet the criteria for SUD are unable to achieve remission without formal treatment. This is our clinical frustration. Many millions of affected individuals require some combination of acute care, medical stabilization, long-term recovery management, and recovery support service to sustain remission akin to the care of other chronic conditions such as diabetes and hypertension. So when you read that, what are the words that scream out to you from that? Because this says a lot about why we do this. And I'll pick
The,
you for that one. You can wait,
the
Chimoke. Pick that one, you for that one, Fide.
So what are some of the terms that stand out?
What screams to you from this?
I think it's the fact that they just have a lot of health conditions that they need to manage all at once. For example, like the long-term recovery management or recovery support systems to sustain remission,
Hmm.
like that just tells me that it's not something that will take a short period of time for them to manage. It will take a while.
So it's not
And
simple. 100%. Not
yes.
simple treatment,
Hmm.
but it breaks down the type of
Yes.
treatment and gives us some insight into
Hmm.
where peer report, peer support services really helps the patient. So acute care is dealing with things like accidental overdoses, having things like Narcan available and so forth. Medical stabilization, once folks experience a relapse, they go to the hospital and they are admitted, they are medically managed. And long-term recovery management after they leave the hospital and their access to services and so forth. What we find when we look at the literature and what the studies tell us, though, is each of those different steps along the way offer an opportunity for getting the patient involved in peer recovery services. And what we'll see is things like accidental hospitalizations, extended hospital visits. These are some of the most effective times to get people involved into peer services directly. Also, clinic appointments and so forth. But let's see exactly what the research says because they looked at specific studies. We'll put that to the side. What was there anything else? I see things about chronic conditions here, and I was wondering if you had any thoughts about that. We'll go with you, Jim. Okay. Why are we talking about chronic conditions here? What's the comparison?
That SUD can be um,
Oh, sorry, we got a hand. I've got to interrupt you. Jacob, what do you got for us? We're talking chronic conditions. What's the connection?
It's a disease. I mean, like they related it to diabetes and hypertension. SUD often, I mean, it needs to be treated more like it is a disease. Unfortunately, we know that that does not happen in our medical systems, but it is a disease, and that's how it should be treated.
And I'll ask you, Jacob, again, could you tell us who you serve and how you serve them?
So traditionally, my service comes from working with people living with HIV. And ironically enough, I think the idea of peer support comes from the HIV field, and then it came over to SUD. I could be incorrect in that, but I thought that was how that worked. But I'm now transitioning to a program that is we're getting ready to launch an SUD medication assisted treatment program here at the health center I work for. So my role is shifted.
That's fabulous. Congratulations. That's very important work. But I have a follow-up question for you. You mentioned HIV, which is interesting because we're starting to think of HIV in the same way, or we started to about 10, 15 years ago. We think of it as this is a chronic disease that people with this condition can live very healthy, long lives as long as they receive an appropriate treatment. And what I'm hearing from you is the same thing is true with substance use disorder. And I couldn't agree more. These are folks that are engaged in recovery for a very long time, in many cases for the rest of their lives. And that perspective is a perspective that allows us to support them and understand that this isn't something that just switches off. You don't just have a relapse, go to the hospital, go to outpatient therapy, and then go home fixed. Fide, did we have some comments?
Yeah. We also had a comment from Whitney saying that's why she joined the webinar to learn how I could use this information for the community that we were in a grant to assist with.
Cool. We'll just keep diving in. And what I'll say is, Whitney, raise your hand if you want some more information about this, about the things as we're speaking, because we're going to be going quite yeah, HIV/AIDS. Well, I'll tell you, peer support is a modality that is successful in both of these conditions. And as our colleague gave us an education about that, apparently there's a connection there directly between the fields. And when I hear that from you, Jacob, it makes a lot of sense because the practice is very similar. When you have peer support, these are very difficult conditions to manage. That's what it gets down to day day in people's lives. You need to go to a clinic, you need to have medication. There are different doctors for this, and there are different referrals. There is a navigation that goes to it, and that's very similar to HIV care. And what I'll say is, your problem, throw some community health workers at it. Being able to give patients the ability to network their care and to talk to other patients that can help them understand sort of the battlefield that they live in their communities is empowering. So that's one step for you there. But let's get to the next. I just really wanted to conceptualize a couple of things here. One, the treatment is always interdisciplinary here. It's never not if it's effective. And two, those different pieces need to respect and understand each other. And the other thing is, this is a chronic disease that we are managing. Think of it like this. Next subject. Next slide, please. Thank you. Okay, and this kind of gets to the details here. What's the special sauce here? These folks aren't magic. You know, they're normal people, and the key is the learned experience. And what I want to read what they have here and pull it apart a little bit. Peers have the ability to engage patients outside the confines of traditional clinical practice. The ability to fill critical care gaps is the probability for the reason for their most widespread uptake. Okay, what's the real reason behind that? And I think it gets back to that complexity and the importance of emotional and social support during this. Peer support, these folks aren't magic, but what they do have is a shared lived experience. And for individuals that are going through that, that provides a emotional and physical foundation that facilitates the rest of their recovery. Next slide, please. Okay, so we're going to go into the methods a little bit. Next slide. Okay, so this is a systematic review of literature. Basically, this is a meta-analysis. And when you see a meta-analysis, this is something that is used multiple studies in a single field. They are helpful when you are trying to translate things to practice because they are very high up in the scientific pyramid, all the way towards the top. So these are things that when we are talking about evidence and we are citing a meta-analysis, we can talk with authority. When you're looking, and we get a question about that coming up. And this question is going to be for Jamoke. Next slide. Jamoke got her MPH last year, so she hasn't seen any of these, by the way. These are total surprises. And that's by design. But you got your MPH last year. I wonder if you can answer this question for me. Which of the following study type has the strongest level of evidence for integration into clinical practice? 1, a case study that is almost identical to your current patient. 2, a retrospective review article recently published by JAMA. Ooh, fancy. A case control study that was performed in your state of practice. A meta-analysis of prospective studies that is directly related to your patient. Does anyone have hands before I feed this one to Jamoke? Put that MPH to work. What do you think?
4.
And it's like math. You got to show your work.
Okay. No to 1 and 2. 2 because it's a retrospective review, and oh
no, you're right. Get rid of them. Yeah, 1 and 2.
1 and
Done.
2.
Out the door.
2 because it's retrospective. and one because it's an ongoing case study and there might as well, you could be writing that case study. That's your current patient.
Remember, we're thinking the pyramid of evidence. Look at
Oh,
all of these.
you need established.
Look at them all and just pick the best one. It's not the SATs. You can't eliminate them. You got to take them all into context. Which is the best for you right now? I hate those questions, which is why I wrote this.
4.
Yes, 100%. Why?
Because it establishes like multiple people have come to the same conclusion and it gives you a background for what you're currently studying.
100%. And if you wanted to say that in something quicker, is in just fewer words, you'd say it's higher up the evidence pyramid, right? Meta-analysis analyses are in this context always the better choice. A case study, that's just one patient, right? Might be exactly like your patient, but you don't know the differences. There's no statistical power to that. You go to a case study like that if you've got them something very specific and you've read all the other stuff already, right? Different situation. A retrospective review article, well, this is looking at data and they didn't see the patients. They're just looking at the data. That's got some power, but not enough here. A case control study, that's good, but it's just one. But if I only had that, that would be an excellent choice. A meta-analysis of multiple prospective studies is the best choice because it has way more into it. There's way more studies, bigger populations, more statistical power, and you can speak about it with more confidence. And you can apply it to your practice with more confidence. Next slide. Okay, so in these they always do this. And Fide, could you grab the comment for us, please?
Sure. So this was a comment directed to Whitney. A lot of
Okay, my
sorry.
mistake. I'm jumping into the
Yeah.
conversation here. Sorry,
Yeah.
guys. I do that. It's the Italian. We do that.
No
Sorry.
worries. Yeah.
Well, getting to this, so this is how they always put these in meta-analyses, but it always just shows how many studies they used, how many were in. In the end, they used 24 of them. That's normal, but we always take a look at this stuff to see how many they eliminated and how they did it. It helps you to understand the integrity of the study. This is a good study. Next slide. Next slide. And I encourage you guys to look at these things when you have time. The knowledge and the experience really accumulates. It's like this stuff's like learning another language. It's certainly how it feels and how it felt. Okay, let's get to the results here. So what we're going to do is we're going to look at these results, look at cases bit by bit. So, Jimoke, you were up. Can you read the highlighted portion? And this is from the randomized control study results. So this is what we can take out of this paper. What does the highlighted portion say?
Compared to controls at 6-month follow-up, participants received a brief peer support intervention were more likely to be abstinent from cocaine and trended toward greater heroin and combined cocaine and heroin abstinence, with a p-value of 0.05 and odds ratios of 1.51 to 1.57.
Tell me what an odds ratio is, and tell me what that one tells you. If you don't know, fine, but take a whack at it.
Odds ratios are, do I remember what an odds ratio is? How they
Increased likelihood is there. I'll give you a hint. Increased likelihood there of experiencing something.
So towards abstinence.
Abstinence is the thing. And we have the normal population is 1.0. And the people here experienced a 1.57 odds ratio of abstinence. What that means is they are 1.57 times more likely, 57% more likely to be abstinent if they were on peer support. And odds ratio, I put you on the spot there because these things sneak up all over the place. And you'll see them in papers all the time. And they can tell you a lot if you see that. So I'll tell you. So one is sort of the borderline for positive relationship. If it's above one, it's a positive relationship. And if it's below one, there's no relationship at all. So if I told you that the odds ratio here was 0.8 to 1.2 was the confidence interval, is that good or not?
No.
Mm-hmm.
Yes. 100%. So always check these things. And if you see it consistently over one like that, that's a strong relationship. So when I see this, it tells me that compared to controls, people who don't go through peer support, there was a 57% increase uh, outcome of abstinence in the study period. That's a huge deal, guys. That's a huge deal. Um, let's translate that. Next slide. Okay, to practice. Fide, I'll hand this to you, and then we'll ask for hands. And if there's no hands, it's all yours. I promise. Um, so you are a community health worker. Any CHWs up there? Here's your moment to shine. You are a community health worker considering referring a patient to peer support recovery services for intervention. The patient is a 45-year-old woman with a history of opioid use disorder, and she's had 3 accidental overdoses since 2015. 3. That's what, 8 years. Based on what we have reviewed, what benefit might this patient receive for engaging in peer support services? So we've got this patient, multiple relapses. Why would we give her peer support? How is this going to help this patient based on what we've read? What are they going to experience positive? Hands and then Fide. Whitney, it's all yours. Well, first tell us, introduce yourself and tell us, who you serve, how you serve them.
I am the Director of Quality Improvement and Risk Management for Regenesis Healthcare. We're a federally qualified health center in the upstate of South Carolina. We're based in 3 counties. And we do have an in-house medication-assisted treatment program. We partner with a couple other community agencies to offer the inpatient and detox services that accompany some of those patients' treatment, depending upon the plan that's created for them, of course, based upon their individual situations. And we recently got an Ending the HIV/AIDS Epidemic grant. And so we were looking to hire some peer support specialists to assist us with that grant in particular. But I'd say the majority of the information that we've received on getting that set up has been from substance use disorder treatment professionals. So in this situation, I would say that from everything I've been learning, the patient would first of all receive encouragement and empathy versus just sympathy from someone who's actually been in that same situation and can, and like I said, encourage her that things can get better. I think that sometimes, like when you're in something and you feel like you're by yourself, it's kind of hard to, if that makes sense.
That is what I've heard, and that's what the literature tells us too, Whitney. You're 100% right.
Mhm.
Thank you very, oh, by the way, doing fabulous work there. Congratulations to you and colleagues. Keep it up. It's
Thank
great to
you.
hear. When I'm thinking of outcomes, and Jacob, I want to throw the ball to you because we said HIV, and we're thinking about that these systems help these 2 chronic diseases in very similar ways. What comes to mind to you?
I'm sorry, can you clarify? Because what comes to mind in helping this individual, or
What is that? What are they? This individual has had no peer support. What are
okay.
they going? How are they going to benefit from it, from their perspective?
I think the strongest thing is it gives this individual someone to identify with. And I think Whitney hit the nail on the head that it's at least someone that they can tangibly feel empathy from. Um, it's easy to say, in a clinical role that you go in and your doctor empathizes with you, or your other clinicians empathize with you. But that's harder and harder sometimes when we have 15-minute appointment times in order for them to go through. Peer support can spend more time with people. They can meet them where they're at in the community. They may even, I mean, I would hope they don't necessarily know them from the community, but they might know them from the community or from their substance use days. It's someone that a person can identify with. It's really powerful to have someone sit across from you and say, while our stories are not the same, I've been through this. I understand.
Mm. So my follow-up for you is, have you ever known those people going through that transition from not having that service to having that service? Because you explained it in a very detailed way. And if the answer is,
Yeah.
how does that look for you when you're seeing these folks that all of a sudden they're being supported? Like, what does that look like? How are things different?
So this involves me disclosing. I've been a peer supporter. I've been on both sides of that, I suppose.
I love it.
So it
Happy to
can
have you.
it can make a huge difference in someone's life and the trajectory of their lives, as long as you have someone in place that respects that at times we're really talking about life and death situations. You want to make sure that you have someone that's able to not only be not only to use professionalism, but know when not to be professional, and know, keep their boundaries, maintain their boundaries, make sure that they're friendly, not friends. But it can really change the trajectory of someone's lives. For me, it was someone that I identified with my own story. Figure out whichever one that is you like. But it put me where I'm at today. So it can have a wonderful impact. Yeah, I feel put on the spot there.
Oh
I'm
no,
sorry, Jacob.
don't worry about that.
I'm sorry, Jacob, but so appreciative of what you're sharing,
Yes.
and thank you for that. And also, it really gives some color to what we're reading here, because when you tell me that story and how that uh, helped your life so much, I think of individuals who I know who are going through this, and I know them when they're in the emergency room, Jacob, and I know them for that. I'm the 15 minutes guy, and I think about how they feel in that moment, the despair, being overwhelmed, and so forth. And when they have spoken to someone like you, and I see them in the outpatient setting, it's like a different person. It's like a different person.
Yeah.
And it's something that makes their life better, but also it saves us a lot as physicians, because they're happier, they're more adapted, and they're getting support, and they're more likely to follow through with resources. It helps everyone.
And I
But
think
please.
it's really important to have peer supporters available in those clinical settings with the doctors, with the patients, have them attend their appointments. I found in my role that often I was a go-between for what the doctor was saying and what the patient could understand. And I think that that's vitally important, is that we tend to take health literacy for granted, and we tend to not necessarily use language that is easily understood. Like, no offense, Dr. Lombardi, but I should have known this. I mean, I had to look up and make sure that I had a clear understanding of what meta-analysis was. So, when we were talking about, and I did, but I had to make sure that
I've been that guy too. I've been that guy too.
So,
And
yeah, that's my
the
piece.
the power I want to put in your pocket, Jacob, is being able, when we are in this work, we need to advocate for the things that we do. Budgets can be scary sometimes, and things can be tough. And just because you have peer support now doesn't mean you're always going to have it. And I can tell you the horror stories of programs that were there and funding went away. as folks in this industry, we need to be able to really talk about the research with authority. And when you say something like this and someone asks you, why is peer support important? You got to be able to give your elevator speech. And what I'll tell you is, plain and simple, it lowers rates of relapse. It lowers rates of overdose. That's what the paper says, and that's the truth. Lead with that and swing that around because it puts it at the priority. It puts it as a priority for organizations and helps keep yours informed. Next slide, please. Okay, we're going to go into the meat. Next slide. I was really liking copying and pasting today. Let's get some outcomes out of this.
Oops.
And one more, please. There it is. Okay. Oh, you know what? I think there's a lag, Fide. That's
I
what it is.
know. It's my connection here. Hold on.
Okay, so let's look what folks do here. So this is one of the major studies they used was
I am so sorry. It keeps changing.
no worries. We'll catch it. It's like music. Outpatient treatment at the Veterans Administration. So this is outpatient OUD treatment. So it showed what the peers actually did. And they evaluated those steps. And what they see is when the outpatient setting, someone is there for outpatient treatment, and this was the opportunity to get them enrolled into peer support. What they found is when they approached people in the outpatient setting, and the peers would basically give them a personal history, would be introduced to the patient, give a personal history, agreed to meet the participants, but the key part is here to attend a meeting with them. And I'm thinking of all the stuff Jacob had told us, the collateral about the experience and what is baked into that. But what did that mean? Those individuals were much more likely to attend meetings, 12-step meetings. They were more likely to and had a greater frequency of attendings at these meetings. And this core piece that I want you to take away from this is peer support supports other things too. And this showed that this effect size here, 0.89, is big. This means that individuals who were approached by peer support individuals in the clinic were much more likely to engage with that long-term treatment, to begin that chronic management of the disease. And it emphasizes the importance of those contexts in recruiting patients. And Jacob, you mentioned this. I've mentioned it, but there are certain areas where the data tells us and experience tells us that it are great opportunities to recruit patients. One, when they are in the hospital, have a peer support person go into that room and talk to them, introduce themselves. They're a captive audience, whether we like it or not. And it's an excellent opportunity. And we'll get into the data with that in a second. And the second is in the outpatient setting. When those patients are at their clinic appointment, have someone sit down with them and introduce them, your program, and get them involved. What the data tells us is it works. They're more likely to show up to the meetings, and they're more likely to attend more of them. And that's what we want. Next slide, please. And Fide, if you can see, keep an eye on this the chat to see if anything's for me. The next slide, please.
Well, I am really enjoying seeing the conversations that the participants are having among themselves.
These guys are chatty,
Yeah.
chatty.
Yeah. So
You know what? I will say, this is how you meet folks, and this is how we support each other. So good for you guys.
yeah, exactly.
We got Mrs. Ramirez. Okay. Mr. Ramirez is a 24-year-old man who is admitted to the hospital after an accidental overdose. Per facility protocol, he's referred to social work for discharge, normal hospital stuff. When preparing Mr. Ramirez for discharge, his social worker considers a range of supports, including peer support services. So, this guy's in the hospital. What can you do, the social services worker, to make it more likely that he's going to attend the meeting that you're going to tell him about, or that someone can tell him about? What can you do? This is your opportunity. Take it. What do we do? We'll do hands and then Jamoke, your turn. If no hands. It's yours.
Peer with a peer support person immediately. Have someone that he can talk to before he even goes to the meeting and maybe go to the meeting with him.
Yes. Use this opportunity to introduce the patient to the system. Being in the hospital after overdose, I don't know if anyone's worked in the inpatient setting, it's very uncomfortable. It's a very uncomfortable experience. It's also very emotionally trying from an individual's. You wake up sometimes in the ICU. The last thing you remember is God knows how long ago. It is disorienting. It is scary. Has anyone ever woken up with a tube in their mouth? Let me tell you, that is the kind of thing that people have nightmares about because it's that scary and that's their life in those moments. Even if they're not in the ICU, if they're in the medicine ward, they're going to be going through very close to going through. They're going to be experiencing severe tachycardia, pain. Depending on what it is, if it's opioids or detoxification from alcohol, there is a whole spectrum of different uncomfortable and emotionally difficult situations that the patient will be going through. And having the opportunity to speak to a peer support person, someone who can reach out to you in an appropriate time in that recovery, normally just before discharge. Do not send someone in when someone's still actively in withdrawals. That mistake is made. When someone is readying for discharge, that is the time to send someone in because it is at the forefront of their mind. They are open to it, in many cases, more likely to be open to it. And when you hear people who have experienced overdose talk about their from the doctor perspective, when you hear folks talk about it, they often describe these overdoses as life-changing situations. And when they do that, there's almost always a person they talk to along the way that helped push them there. And there is the details of each narrative. But it speaks to the importance of these moments. When patients are in the inpatient setting, when they are readying for discharge, the data tells us this is the best time to talk to them. Just plain and simple numbers. We can there. It's a beautiful thing seeing it happen. So if you have an opportunity to recruit people through the inpatient setting, use it. Is what I'll leave you for that. And with that, with no thoughts, we'll go to the. If there are no thoughts, we'll go to the next slide. So I'm going to pick this stuff out of here pretty quickly, but some more data. Here we see okay. Similar studies we're looking at. Okay, peer support increases. You have a 10% increase rate of attendance at 12-step meetings. Increased re-meeting attendance. Rates of post-discharge meeting attendance are significantly higher. It's more of the same. The data is telling us that peer support, in addition to what it does, it increases patient participation in this chronic condition. Next slide, please. Okay, and I think Fide, this will be yours, and then to the hands. Do I have the order right still? I think so. Correct me if I'm wrong.
Yep.
So, you are a community nurse who is reviewing the SCRH screen and medical record of Mrs. Jones, a 54-year-old female with a history of social isolation, intimate partner abuse, and OUD. She's experienced one accidental relapse in 2022. So, here's the problem. She has previously refused to attend 12-step or OUD recovery meetings. And refusal is always what it will say written, by the way. I know that the term is to some folks a oversimplification, and it is. What refusal looks in this case is this individual was not interested. She had been offered. She's, no, not for me. It's not for me. I don't know. This is someone who's experiencing social isolation, keep in mind. How could recovery services help encourage this patient to access more programs? She's not accessing OUD recovery stuff right now. She goes to peer support. How could it help? And Jake, I'm sorry, but I want to ask you for this because I feel like you had an awesome answer for us.
Had to find my mouse. I'm spread across 3 screens here. So the first thing is, because she declined, refused, she declined services, and it's not anything. But I think the one thing that it could really address is social isolation, if not anything else. There is an epidemic of that in our country in and of itself. So having that is really important. But I think that also just having her talk to someone that is in recovery could give her that outlet and recovery program that she's looking for. One thing that and I've noticed it's brought up a lot, maybe it's because of the literature that we're using, but is the reference to 12-step programs quite a bit. And while 12-step programs are fantastic for the people that they work for, they don't work for everyone. And we have to keep in mind that everyone needs an individualized plan that is catered to them. So I think that if this individual had a peer supporter working with her, she could have access to someone that could meet her at her own home, that could work with her on what she finds to be the most pressing. Further, she has been the victim of intimate partner violence. So that's something that should be ongoingly assessed, and whether or not she actually can get out to a 12-step program. So connecting her to services that might be specific to women that have experienced partner violence, connecting her to services that might relate to OUD, or, just meeting her at a coffee house so she gets out of the house. I don't know if that answered it, but that's my take.
No, 100%. And you're giving me the perspective that I just don't see. We miss this all the time because on a medical record, or when I'm seeing the patient, the thing that translates into our mind is refusing therapy. That's it, right? We have a much simpler perspective of the social context there, which limits clinical action is what it does, and it limits how we can take care of the patient. So that narrative behind that is so important, because clinical folks often forget just how complex this is for folks to navigate. And when you speak, I'm thinking of, what do our community health workers do in this and other complex social situations? Is they do exactly what you're saying. They coach and they individually tailor therapy. And so everyone with OUD is going to need a different connection, is going to need a different group of resources, is going to respond differently. And that's the beauty of our community health worker colleagues, is they are able to address that issue in a way we just can't do in the clinical realm. We don't have the training for it, we don't have the knowledge for it, and we don't have the connection to the patient that the community health worker has. And let me tell you, they are the best salesmen for this stuff too. Oftentimes, like you said, they are from the community, and sometimes community health workers, depending on the context, may be peers themselves. So, things to consider. And another thing to get across here is the importance of momentum. OUD is difficult, and everyone's story of why they're involved with the condition, why they have the condition, and is very, very different. Different social factors, family issues, STOH issues, other medical issues. Everyone's story is incredibly complex, which makes it difficult to manage. But the thing that I would focus on is momentum towards recovery, and accessing services is a very good metric for that. Someone like this who is in peer recovery services is going to, through their emotional connection and relationship with other peers, learn about what's available. That's a big part of the conversations that folks have. Being able to navigate resources and being able to hear from someone who you trust, who's navigated them before. Because when I'm thinking of myself saying this stuff, or someone who delivers peer support saying this stuff, they don't listen to me. they listen to that person. And the reason is when someone has experienced that, the same thing you have, there's just something there that the doctor will never be able to have in that communication. It's an intimacy, it's an understanding, it's a trust that is unique to peer support. Next slide, please. Okay, moving on. This is more for the review for those who get the slides. The next slide, please. Okay, so it's some more stuff from the Medicaid data. And this is from using government and Medicaid records. The researchers looked at large numbers of records of diagnoses and outcomes to see, does this stuff work? And what the survival analysis over a 3 years period, which is when they analyzed, indicated that peer support programs, one, had peer support participants, one, had longer times living in the community without rehospitalization. That's a big one. Two, lower overall number of rehospitalizations compared to a sample comparable control group. What that it says to me is fewer relapses. And what that says is that's a very powerful statement because it's usually using government health records. Those are very clear outcomes. Next slide, please. Okay, let's apply it. Jim, okay, this will be for you if no one else wants it. You are a community health worker evaluating the social needs of a patient. Patient is a 59-year-old woman with a history of opioid use disorder with 3 accidental overdoses since 2015. The patient has intermittently experienced homelessness since 2023. Okay, so we have OUD, history of overdoses, experiencing homelessness intermittently. How could this patient benefit from peer support services? And what services would you implement alongside? What do you think? While I grab my coffee, take a shot.
Like we've said, someone who can empathize as they've also been through or have struggled with SUD. Other benefits, I guess, someone to navigate their care with. I know
That's a big one.
going from doctor to doctor can be very daunting, and the different referrals and different clinicians that you'll have to see. And then other services, as they have experienced homelessness, is housing can be very big. So if there's a peer support person can introduce them to different programming, maybe get them into a housing facility that I'm sure there's other programs that also, I guess, pair with substance.
You're nailing it.
And
You have
having those
research.
guidelines would help.
Predicted the research once again. And this is a very important point, is when we look at folks who have experienced peer support, they're more likely to have accessed housing in 6 months than folks that don't. And that tells you a lot about the network that peer supports gives folks, because they're not just talking about recovery services or recovery treatments, other programs. They're talking about other stuff, which is like they'll probably spend a lot of time, who knows, talking about tomato plants or sports for all we know. These are real relationships, and they can get really close. And trust and believe that from your peer, you'll get a lot of support in how to get other things as well. And effective peer support programs are those that intervene in things like homelessness and housing insecurity, food insecurity broadly, because they are exceptional networks for that. They are exceptional networks. So what I'll say, the takeaways from that are two. One, if you're a program that it may benefit from a partnership with a peer support network, consider it. Because if you're distributing supplies or access to resources, that's a great network to get people to use those resources and discuss them with other folks in the community too. Like email, right? Social network that is valuable for finding folks who can use what you have to give. And two, as a peer supporter, understand how important that is. That the little things that you do, like show folks opportunities for intervention in their life, opportunities to access social services by just telling them how to do it, what building you go in, what forms you fill in, talking about your experience, it leads to more uptake. How that gets to there, for each person, it's a little different. He felt encouraged, they were shy, who knows? All this was very difficult, it's overwhelming. Everyone has a different story, but what we know is peer support helps them get to that endpoint, and it increases that likelihood significantly. Jake, you got anything to add about? Oh, we have a couple of minutes. I'm sorry, I got to take it from you. We got a couple of minutes, but I love what you're saying about stigma because it's a major barrier. And if when I think about the peer support, what it can do there, oh boy, howdy, it can really destigmatize this process to people and empower them and empower them. And let me tell you, from a physician's standpoint, when these folks are working with folks like you, it's great to see them empowered because they feel great and they're happier. Next slide, please. Yeah, okay, there we go. Yeah, another practice tip here from the paper. Here, the recruiting for this peer support was in the outpatient setting, and individuals who were experiencing OUD or had a history of OUD, peer supporters would be there in the clinic, and they would go and talk to them in a private setting and talk to them about these issues. And through those conversations, get them to come to peer support meetings, enroll in programs, and so forth. That is an intimate connection, and it's one of those opportunities for intervention where you can change someone's life and save their life. Is those clinic appointments, those inpatient visits. Next slide, please. Just to summarize here, some takeaways on the role of peer support in the following context. Clinical settings are your opportunities for recruitment as peer supporters. They are the network. In the outpatient setting, finding peer support individuals that can either be on clinic, be on call, or physically there, and be alerted to individuals that have this history and may benefit from a conversation. Similarly, in the outpatient setting, a referral to peer supportive services is an effective way to get people to uptake these services. In the inpatient setting, make peer supported services part of your discharge planning. Make sure the social workers know the services available. They know the peer support services providers themselves, and the opportune time to talk to folks is in the 24 hours before their discharge. Social services, of course, community health workers are the ideal professionals to sell this product to our customers. They understand the community. At times, they are users of the services themselves, and they have the time to explain it. Community health workers are our friends here. With that, I will say thank you all for your time, for your service to your communities, and your participation today. And what's sunny here? Hope it is over there. Enjoy the weather. If not, yes, it'll come.
Thank you so much, Kevin. Thank you for that optimism as always. And thank you all for also participating in today's sessions. Your experience and everything that we learned from you is also very valuable for us. And I really enjoy seeing that you guys are getting to like know each other in the chat. So that's very great. This is also just a reminder to please complete our post-evaluation survey, which is going to pop up on your screen right after the session. And again, look out for our latest publications, the webinars and LC sessions on our website. And we look forward to seeing you all again next week at the same time on Monday.
Will you be sending out these slides? Because I saw a survey that I want to rip off because I'm currently writing intake documents. So I saw something that you flipped through that I want.
Okay. Yeah, of course. Yeah.
You could send those out. I would appreciate it. I'm not trying to reinvent any wheels ever. Thank you.
No worries.
We got wheels.
No worries.
We got wheels for you.
That's what we're here
everyone,
for.
Thank you for your service. Thank you for your service, everyone.
Thank you.
Have a great day.
Making our communities better. Thank